Welcome to the deep dive. You can almost feel it in the air, can't you? That hint of autumn, meaning flu season isn't too far off?
Definitely. And community pharmacies are right there, gearing up.
Absolutely. They play such a vital role. So today we're going to cut through the noise around a really critical piece of guidance that's just landed, the 2025-26 Community Pharmacy Seasonal Influenza Vaccination Advanced Service Specification.
Yeah, the new spec. Always important to get across the details.
Exactly. We've gone through the official publications, Community Pharmacy England, NHS England, to sort of boil it down for you.
Yeah.
Our mission really is to give you that shortcut. What's new, what's changed, and what does it actually mean for healthcare in your community? Okay, let's unpack this.
Yeah, and maybe just stepping back for a second, it's worth remembering why this service is so crucial. It's not just about, avoiding a cough and a sniffle.
No, much bigger than that.
Seasonal flu puts huge pressure on the NHS. Think unplanned hospital admissions, pressure on A&E, and of course the impact on vulnerable people can be really severe. So expanding access through pharmacies, which has been happening since, 2015, that's been a key strategy. It's all about maximizing uptake in those at-risk groups, protecting the most vulnerable, and just making it easier for people to get vaccinated locally.
Convenience is key, isn't it?
Yeah.
So we know the general service, it's familiar.
Yeah.
But you mentioned the new spec. Are there actual changes, little tweaks in the fine print for 25-26 that people need to be aware of?
Yes, there are a few. There may be a subtle but significant changes compared to last year. A lot of it seems geared towards tighter governance, better patient safety, and making things more consistent across different pharmacy services.
Okay, like what?
Well, one of the main things is clearer wording around supervision. It's now very explicitly stated that the responsible pharmacist at the registered pharmacy premises is professionally responsible for overseeing the whole service.
The whole thing, even if it's not happening right there.
Exactly. And that's where it gets interesting for off-premises vaccinations, say in a patient's home or maybe a care home or a community venue. For that kind of provision, there needs to be an on-site pharmacist or even a pharmacy technician who is explicitly linked back. They have to work closely with the responsible pharmacist and the superintendent pharmacist.
Ah, the superintendent too.
Yes, through a proper governance framework. The superintendent kind of oversees the clinical governance for the entire pharmacy business, you see. So this framework ensures that oversight is robust. Even when the service moves outside the pharmacy's four walls, it sort of closes potential gaps.
That enhanced clarity, the supervision for off-premises stuff, is that going to be a big hurdle for pharmacists? Or is it more just writing down what good practice look like already?
I think it's largely formalizing best practice,
Yeah.
but it does introduce a new specific requirement that might feel like an extra step, at least initially.
Which is?
Pharmacies must now actually seek permission from the commissioner before they do any vaccinations away from the main premises.
Right, get the okay first.
Yep. Whether it's a patient's home, a care home, some community pop-up. The idea is that commissioners need full visibility. They need to know that the right conditions and governance are in place wherever vaccinations are happening off-site.
Okay, that makes sense from an oversight perspective. Anything else?
Yeah, there's also standardized wording added throughout the document. Seems minor, perhaps, but it's about bringing the flu service spec into line with other advanced services pharmacies offer.
Like the blood pressure checks, that kind of thing.
Exactly, like the hypertension case-finding service. It just makes it easier for pharmacy teams who are juggling multiple advanced services if the language and structure are consistent across the different guidelines.
Streamlining things a bit.
Essentially, yes. And one final point on changes Appendix B, the bit about vaccines. It's got more specific details now on which vaccine types can be used for certain age groups, especially those nearing an age threshold. For instance, if you're 49 but you'll turn 50 by the end of March 2026, you're eligible for the adjuvanted trivalent vaccine, ATIV. And, similarly, if you're 59 turning 60 by that same date, you qualify for the high-dose quadrivalent or trivalent one, the QTIV-ASHI. It just gives pharmacists that extra clarity on exactly who gets which specific vaccine type, making sure it's the most effective option for their age.
That's a really helpful breakdown of the tweaks. So that covers the what's new. Now, the big question, when? When can pharmacies actually start giving these jabs under the new rules?
Right, the timings, they're staggered, which is important for everyone to know, pharmacies and patients alike.
Okay.
From September 1st, 2025, pharmacies can only vaccinate pregnant women. That's the first group.
A targeted early start then.
Precisely, for a particularly vulnerable group. Then, from October 1st, 2025, that's when vaccination opens up for all the other eligible adult cohorts.
October 1st for everyone else.
Yes. And the overall aim, like previous years, is to get as many people vaccinated as possible by the end of November 2025, before flu really starts circulating widely.
Get ahead of the curve.
Exactly. We're also still waiting for the full patient group direction, the PGD, and the national protocol. They should be published very soon, and they'll have all the detailed clinical guidance pharmacists need.
Okay, good to know those are coming.
Right.
So with the what and the when sorted, the next obvious question for anyone listening is probably, well, am I eligible? Am I on that list?
Yeah.
Let's dig into who exactly this service is designed for.
Yeah, absolutely. The service covers eligible adults, so that's 18 and older, and Annex A of the specification lays it all out. It's quite comprehensive.
Let's break it down.
Okay, first up, age. Pretty straightforward. Anyone age 65 or over is eligible, and that includes people who will turn 65 by March 31st, 2026. So if your birthday falls before then, you're in.
Got it. 65 and over.
Then you have the clinical risk groups. These are for people aged 18 up to, but not including 65, and this covers a really wide range of underlying health conditions.
Right, the at-risk categories.
Exactly. Things like chronic respiratory diseases, severe asthma needing continuous steroids, COPD, cystic fibrosis, that sort of thing. Also, chronic heart and vascular disease, so chronic heart failure if you've had a stroke, peripheral vascular disease. Then there's chronic kidney disease, chronic liver disease.
It's quite extensive.
It is. Chronic neurological conditions too, MS, Parkinson's, dementia, cerebral palsy, severe learning disabilities. Diabetes is a big one, any type, even diet-controlled. Adrenal insufficiency too.
Wow.
And a really important group, people with immunosuppression. That could be due to a disease like HIV, or treatments like chemotherapy, organ transplants, or even long-term high-dose steroids for things like rheumatoid arthritis.
Okay.
Plus people with a splenia, no spleen, or a spleen that doesn't work properly, like in sickle cell disease. And finally, morbid obesity, which is defined as a BMI of 40 or more.
That's quite an exhaustive list. It feels like it really tries to capture everyone who might be particularly vulnerable. Are there any sort of new groups on there this year, or any surprises?
It's largely consistent with previous years, actually. I think what's often surprising is just the breadth of those existing clinical risk groups when you list them out. It really shows the NHS commitment to protecting as many vulnerable people as possible.
Yeah, it's very thorough.
And it goes beyond just the individual's condition, too. Think about who else is eligible. Pregnant women, obviously, at any stage. People living in long-stay residential care homes.
Right.
But also carers, those getting carers allowance, or who are the main carer for someone elderly or disabled, and household contacts of people who are immunosuppressed. That's protecting the vulnerable by protecting those around them.
That's a really important point.
And certain frontline social care workers, too, specifically those without access to employer-led vaccination schemes. It's a very comprehensive safety net approach.
It certainly sounds like it. So once eligibility is confirmed, what about the vaccines themselves? Are there different types available through the pharmacy service? Are certain ones preferred?
Yes, the guidance in Annex B is pretty specific on vaccine types. The aim is to use the most effective vaccine for the person's age group.
Makes sense.
So, for eligible adults aged 18 to 64, the first-line options tend to be the newer or more potent vaccines. Things like the adjuvanted one, ATIV if you're 50 or over by that March deadline, or cell culture-based vaccines, high-dose ones if you're 60 plus, or recombinant vaccines.
Okay. What about the standard egg-based ones?
The standard egg culture vaccines, QBIV or QIV, they're now considered second line for this age group. They're only reimbursed if a pharmacy genuinely can't get hold of the first-line options to order.
So a clear preference for the newer types there.
Definitely. And for adults aged 65 and over, the emphasis is even stronger on the vaccines designed to give a better immune response in older people. So first line are the adjuvanted, ATIV, high-dose, TIV, HDQIV, HD, or recombinant TIV or QIV vaccines.
And second line?
Cell culture, TIV, is second line for the over 65s. Again, only reimbursed if the preferred ones aren't available. The clear message from NHS England is that pharmacies should be ordering and using those first-line recommended vaccines.
Right. Prioritize the most effective options. Okay, that clarifies the vaccine side. Now, knowing which vaccine is one thing, but for the pharmacies actually delivering this, there's quite a bit involved operationally, isn't there? The sort of logistical dance behind it all.
Oh, absolutely.
So let's maybe pull back the curtain on that. What are the key requirements for pharmacies to actually run this service properly and safely?
Yeah, the operational requirements are pretty robust, as you'd expect, all focused on patient safety and efficient delivery. Normally, vaccinations happen in the pharmacy's consultation room.
Which has to meet certain standards.
Exactly. Privacy, cleanliness, the right equipment, all meeting regulatory standards. But as we touched on earlier, it can happen elsewhere, community centers, patient homes.
But with caveats now.
Right. Provided confidentiality and really strict infection control can be maintained. And, crucially, remembering that new rule about getting commissioner consent before doing any off-premises vaccinations.
Okay, what about the staff actually giving the jabs?
Training and competence are absolutely paramount. Vaccinators need specific training following the national minimum standards and core curriculum. They need annual updates, mandatory. And face-to-face refreshers are strongly encouraged periodically. Competency has to be demonstrated and documented. There's a declaration of competence framework, or the UK HSA tool for that.
Right.
Plus, mandatory training on things like handling clinical waste safely and what to do in case of a needle stick injury. And if you're going into people's homes to vaccinate, you need a valid DBS check.
A lot of checks and balances there.
There are. And operationally, pharmacies have to stick rigidly to the Green Book. That's the official immunization guide from UK HSA for all the clinical stuff. Dosage, timing, how to administer, waste disposal.
The clinical Bible, basically.
Yeah, pretty much. They also need a detailed standard operating procedure, an SOP. This has to cover everything from maintaining the cold chain for vaccine storage.
Keeping them at the right temperature.
Precisely. Using fridges with Max-Min thermometers, recording temperatures daily. The SOP also needs to cover escalation procedures for adverse events, meticulous record keeping, staff training, and every patient has to get the manufacturer's patient information leaflet.
Okay, and consent.
Data.
Informed consent is absolutely vital, must be obtained and recorded for every single patient before vaccination. And yes, data sharing is a big part of this public health program. Vaccination details are securely shared with the patient's GP, ideally electronically, same or next working day. Also shared with the NHS Business Services Authority, the NHS BSA, for payment and checking. And with the Commissioner or UK HSA for monitoring and research, but that's pseudonymized data for evaluation purposes.
And reporting problems.
Crucially, yes.
Yeah.
Any adverse drug reactions or patient safety incidents must be reported through the proper channels.
And keeping records, how does that work? Pharmacies have to use an NHS-assured point-of-care IT system to record the vaccinations. Ideally, they should do this on the same day the vaccine is given. These electronic records are vital and must be kept for at least 3 years, mainly for post-payment verification purposes. The system automatically sends the data to the GP record and also feeds into the NHS BSA's Manage Your Service Platform, MYS, usually via an API, which is how pharmacies claim payment.
That's a huge amount of detail for pharmacies to get right, isn't it? From the clinical side to the data flows. So moving on to the money side of things then, how do pharmacies actually get paid for providing this vital service, and what checks are in place to make sure it's all above board?
Okay, payment. Claims are submitted through that NHS BSA platform, MYS, and pharmacies really need to be on the ball with deadlines.
Tight deadlines.
Yes. Claims should ideally be in by the 5th of the month after the vaccination was given, and definitely no later than 3 months after that claim period. There is a very narrow 12-month grace period, but that's only for IT problems totally outside the pharmacy's control. And a key point. The vaccination record must be in the point-of-care system before the claim goes into MYS. You can't manually change MYS claims later.
Okay, get the record straight first. And what do they get paid?
They get a service fee for each vaccination they administer. Plus, they get reimbursed for the cost of the vaccine itself, and there's an allowance for VAT included, too.
Right. But what if something isn't quite right, like vaccinating someone who wasn't actually eligible?
Well, the rules are very clear on that. NHS England states that no payment will be made if vaccinations are given to ineligible patients, or outside the specific start and end dates for the cohorts, or if the wrong, unapproved type of vaccine is used.
So strict compliance is needed for payment.
Absolutely. Which brings us to accountability and those checks you mentioned.
The post-payment verification.
Exactly. PPV. NHS England works with the NHS BSA Provider Assurance Team to conduct these checks. Think of it like an audit. They verify that the claims made match the service actually delivered.
And pharmacies need proof.
Yes. They must be able to provide clear, verifiable evidence, usually those electronic records we talked about, to back up their claims if asked. If a claim can't be verified, maybe the documentation isn't complete or accurate, it could lead to NHS England recovering the payments made.
Wow. So that really hammers home the need for meticulous, accurate record-keeping for every single jab.
It really does. It's absolutely essential. It ensures public funds are used properly for this really important public health service.
It's so clear listening to all this, just how much community pharmacies are doing, isn't it? Really on the front lines, constantly adapting, expanding what they offer.
They really are.
They're becoming so much more than just places to pick up prescriptions.
Yeah.
Proper health hubs, taking on these quite complex clinical roles.
And what's fascinating, I think, is how this incredibly detailed service specification really highlights that expanding clinical role. This isn't just about basic dispensing anymore. It's about providing complex, critical public health services right there in the community.
Yeah.
The level of detail, the governance, the training requirements, it all reflects the growing trust and reliance the NHS places on pharmacies to deliver this kind of essential care safely and effectively.
Absolutely. And it definitely makes you think. As pharmacies keep taking on more advanced services like flu jabs and doing it with this level of oversight and competence we've discussed, what other essential health services do you think could potentially benefit from being more accessible right there on the high street through your local pharmacy?
It's a big question.
How might that continue to shape the future of healthcare for all of us? Something to ponder. Thank you for joining us for this deep dive.